Mhm. Hello. Morning.
Good morning.
Right. Give it a moment. You guys can see this screen here, the big screen, right?
Yeah.
Thank you. Give it 30 more seconds and we'll get going. Everybody have a nice weekend?
Yes,
Yeah.
thank you.
Yes. This was very cold.
Yes, it was. Oh, Christina, were you away? I think you were on vacation. Is that right?
Yes, yes, I was on vacation the last 2 weeks.
Anything fun?
I went skiing in Italy.
Whoa. We're paying fellows enough to go skiing in Italy? What's going on here? I gotta talk to Lamar. That sounds pretty nice.
Yes, it was very nice. Not as cold as it is here.
Well, of course not. And I'm guessing the food was marginally better there as well.
Yes, just a bit better.
Any bit. Okay. All right. Let's move forward. So this is a baby who had surgery involving a VSD closure, and you get a call that the heart rate is slowing, and there is concern about this. So my question is, what is this? What's going on? And how might we treat this? So why don't we go to why don't we go to Christina Bezdakova, straight from the Alps in Italy.
Okay, so looking at this EKG, so it looks like it's half standard, and first looking at axis. So
Mhm.
it looks like a right axis, but it's a baby, so it could be appropriate for
Uh-huh.
age. Um, and then now looking at the rhythm, so looking to see if the P waves are upright in 1-2 and AVF, which we see that they are. So uh, looking at that, it looks like we're in sinus rhythm.
Okay.
Um, And now looking at the rate, since that's our primary question. So looking at it, it looks like the rate is regular. Just looking overall at 2 and V2, but the heart rate looks to be about, and I'm just counting it now.
So
The
far.
heart rate looks to be about 60
Mhm.
beats per minute, which for a baby is low, a bradycardic, so sinus bradycardia. And now looking for what could be a cause of the heart rate slowing. I want to look at the P to R interval to see if it is prolonged. I wouldn't say that it's prolonged,
Mhm. No, I agree. I think the
but
PR intervals, on the short-ish side, but
yeah,
normal for a baby though,
hmm
right? PR,
yeah,
I don't know, let's say it's 50 or 60 milliseconds.
hmm and then looking at the QT interval is the next part of when I'm looking at EKGs, and just looking at it, it looks long, but in the context of this bradycardia, the QT, it looks like it's still less than half of the preceding R to R segment. So I would say that it's within normal limits.
And remember also, as a good rule of thumb, if you want to if the heart rate is 60, the QT measured equals the QT corrected.
Mm,
So
that is
the heart
good.
rate's about 60 and the QT is about 400, right? It's about two large boxes.
Hmm.
Therefore, the QTC is roughly 400. So it is not prolonged. Anything surprising or unusual about the T waves, though?
They do look like they're peaked. The T wave is almost the same
They,
amplitude as the R wave.
are they
Uh,
peaked in all the leads or in just some of the leads? Like I agree that in like lead two, it looks like there's a little peak here. There's a little peak over here. So
mhm.
say something peeking in over here. Any thoughts on what that might be? So obviously in the differential would be something like hyperkalemia, but
Mhm.
is it possible? What if I told you that 5 minutes earlier the heart rate was 110? Is there any other explanation for this bradycardia? Is there anything that could be perhaps superimposed on that T wave? I'm going to show you the atrial electrogram because so this patient actually had AtriAmp on, the powerful new tool in the
Mhm.
ICU. And this is the this is actually AtriAmp from the same patient at the same time.
Okay.
So the V lead is the atrial electrogram, and the lead above is lead one.
Mhm.
Does that help you?
Yeah, so you can see with the atrial electrogram, it's how it's correlating to the P waves. And then going back to our EKG, it'd be blocked PACs, resulting in the bradycardia.
That's correct. So the one thing you have to be sure, though, right? So this is the PAC, right? And it's
Mm-hmm.
in retrospect, it's buried inside of the T wave, and the Atra app makes it very, very clear. I would argue that you could tell this based on this tracing, which was all I had when I was asked about this case, but the Atra app at the same time was even clearer, right? Because it augments the atrial electrogram and
Mm-hmm.
records directly from the atrial. But the one thing you have to check is you have to make sure. So this could be, it is essentially 2 to 1, right? You have P wave conducting, P wave not conducting, P wave conducting, P wave not conducting. So if these extra P waves are on time, that's a problem. It means that there's something wrong with the AV node. However, if you take out calipers, you can easily see that this P to P interval is substantially shorter than this P to P interval. This is really at a rate of about 180,
Mm-hmm.
whereas this is, much longer, like 120 or so, 140, 130. So the bottom line is, yes, this is atrial bigeminy. What would you do about this? Well, what's the first thing you want to know about the patient? So the nurse, the NP from the unit calls you and says,
Mm-hmm.
we're a little concerned because the heart rate is 65. And you get the EKG and you've made your diagnosis, but what do you want to know about the baby? So it's good that you understand now what the rhythm is, but
Mm-hmm.
what do you want
I
to ask?
we want to know if they're hemodynamically stable and what their blood pressures are, how the baby is doing.
So blood pressure is important, but remember that changes in blood pressure are amongst the last things to
Mm-hmm.
change, right? Um,
Yeah.
so what else do you want to know about the baby? You know, when you say hemodynamically stable, what do you let's say you're going to the baby, what are you going to check? So the nurse tells you look up on the monitor and the blood pressure is
Mm-hmm.
normal. Let's say it's 75 over 45 in a 1 week old or something. So that's
Mm-hmm.
good. But what else are you going to check in the baby?
Um, how their pulses and perfusion
Yeah,
is as well.
exactly. Pulses and perfusion. And so the baby looks well to you, has good
Mm-hmm.
perfusion, has brisk capillary refill, has warm extremities, pulses are easy to feel. Baby looks well, is not breathing rapidly. So you don't have to rush. You have some optionality now.
Hmm.
So what could you do about this? First of all, does this have to be treated?
No,
Yeah, that's true. It doesn't
you can.
necessarily. I mean, it's possible though that if this were to persist for many, many hours, maybe
Hmm.
the child would get into trouble. But when you look back on telly, you see that in fact this has been going on and off for most of the day. Most of the time is conducting one-to-one, maybe
Hmm.
has an occasional drop PAC. But what if this were, had been going on for say 6 hours and you're looking at it? Would you consider treating it?
Yes, I would consider treating it if it's pretty persistent and it's not self-resolving on its own.
Yeah,
Um,
I think that's right. If it's really resulting in a very slow heart rate, probably we would normally treat it, if for any other reason than to make the people at the bedside feel more comfortable. So multiple options to treat this. So
mhm.
what would you want to, what are the options that we could try?
So if the baby is immediately post-op and still has pacing wires in place, could pace
Yeah,
the
you could
patient.
pace, although theoretically, right, we know that the
Hmm.
general rule of thumb with heart rhythm is that whatever is fastest wins. And so in order to suppress this, you'd have to pace the atrium at rates above 150, 160 or so.
Hmm.
You might not feel comfortable doing that, but that would be one way to suppress it temporarily. But is there anything else you could do medically?
So medically, could you use medications such as
Yes,
propranolol?
medications are good. Doctors love those.
Does
Okay.
that,
Propranolol, sure,
yeah,
that's reasonable, so it's sort of paradoxical, right? You're
yeah.
giving an agent that has a side effect of bradycardia in order to treat bradycardia, but because you're treating an atrial arrhythmia, it's actually an appropriate choice. So
Hmm.
propranolol would be a good choice. Any other options?
You also use amiodarone as well.
Okay, you're an aggressive doctor. That's very appropriate. It's nothing wrong with using amio,
Hmm.
but I think that probably most people would say as a first agent for atrial bigeminy might be a bit aggressive, but
Hmm.
maybe you also work part-time in the resource utilization department and you want to get this kid out of the hospital as fast as possible. So you want the maximal effect. So that's not unreasonable, but for sure we would not use IV amio for this because of the
Hmm.
risks of cardiovascular collapse in infants and such. But
Hmm.
certainly you could load this child with amio. If you were going to load the child with amio, what would the dose be, by the way,
Um,
for the load?
the dose, uh, it'd be 5 per kilo, and then you would go down after 5 days to 2.5 per kilo per day.
No, actually, it's double that. So you would load with 10 per kilo. You're right. 5 per
Okay.
kilo per day is the standard SVT dose, whereas
Okay.
10 per kilo per day is the ventricular arrhythmia dose. But
Okay.
in order to load, we would typically load at double the standard dose. So
Okay.
10 per kilo per day usually would be it. And although the half-life of this agent is very, very long, and you could certainly give it once a day, just give one dose of 10 per kilo. We typically will load at BID, divide at BID. Do you know why we do that? Even though, I mean, pharmacodynamically, it makes no sense, right? Because we've talked about how the half-life of amio can be as long as 30 to 45 days. So really shouldn't matter if we give it once a day or twice a day to load it. But why do you think we load it BID, or do you know why we load it BID, even though it really makes no pharmacokinetic sense?
Is it also to potentially prevent hemodynamic collapse if
No, you don't really
mm,
get that interestingly with enteral loading. I mean,
mm,
you could get bradycardia, I guess, but you don't typically get that. Remember that the hemodynamic collapse that is seen in roughly 5% of infants who get IV amio is due to the diluent in the IV solution. It's not actually, it's like an
mm,
idiosyncratic reaction. It's not from the amiodarone per se, at least we think.
mm,
So thought? The reason we do that is because it causes nausea. So
Oh.
it's better tolerated when it's given
Mhm.
BID at a high dose. You can give 5 per kilo per day once. So amio is a great agent in that it can be given once daily, which is terrific. It's very
Mhm.
easy for parents, but and 5 per kilo per dose is tolerated fairly well. But when you start going above that, sometimes babies and children can be nauseated from it. So we typically will divide it up, but it doesn't have to be. But we often will do that. That's the reason. So yeah, you could use amio. Anything else you could use?
Could use digoxin as well.
Yep, could use old-fashioned digoxin. Dr. Arnon would be very pleased with that. And what would the typical dose of digoxin be?
Uh,
So in the present era, right, you can go to Epic and get the answer, but if somebody said, I need dig stat, let me draw it
mhm.
out of my dig vat, how much would you give? So
Would you
usually, yeah, go ahead, please. I'm sorry
uh
to interrupt you.
so would you load um like 15 mics per kilo per dose?
Well, yeah, I mean, if you're digitalizing, yes, you could give 15 per kilo, or there's all kinds of different ways of
Mhm.
using. But what is just the standard dose that
Uh,
start somebody on if they were already loaded, what would be the standard daily dose of
it
digoxin?
would be about 8 to 10 mics per kilo per day into BID dosing.
That's exactly right. So it would be 8 to 10, except if you're a preemie, where I think it's closer to 3 to 6.
Mhm.
Um, so yeah, the other thing is certain agents will raise your level of digoxin. For example, amiodarone. And so you would want to give less of that. In similar vein, if you're on another agent that causes bradycardia, you probably want to start at a lower dose of digoxin. So yeah, digoxin's a reasonable agent. Flecainide would be a reasonable agent. Sotalol would be a reasonable agent. Any of these really, in theory, could work to treat this. And typically, we would start something simple like a beta blocker or digoxin, maybe a combination of those two. And if that failed, we would switch to something else. But really, any of those are reasonable options. There's no real right answer to this. And in fact, it's not unreasonable not to treat this also. Some people would say, if it's coming in and out, and if it's stopping from the majority of time and the patient is hemodynamically stable, that's fine too. We see this not uncommonly in healthy children in the well baby nursery. It seems like at least once a month, one of us is asked to review an EKG of somebody who's having atrial bigeminy or a lot of blocked PACs causing a slower ventricular rate, and somebody is concerned about that. So, all right, very good. Thank you. Any questions
Thank
about this
you.
tracing or? Very good. I'm glad to see that the time on the Alps was very good for your EP knowledge. All right. All right. This is a 12-year-old with intermittent palpitations, and this is a ambulatory monitor that the patient has. And so my question to you is, and the patient has a resting surface electrocardiogram, which is normal. There's no pre-excitation. So what do you think is the differential diagnosis of this, and how would one treat this? Why don't we go to Dr. Molly Marshall, formerly of Pittsburgh in Indiana.
Good morning. All right, let's see.
Soon to be heart failure and transplant expert.
Lord willing. All right. Okay, so it looks like the first three, maybe two beats for sure looked more to me to be sinus. And I think the third one is, although the P wave's a little harder to see there, but it's about at the same R to R interval. And then you see it pick up to some type of tachycardia, in which the heart rate is close to 200, I would say. It's like between, yeah. And then looking further, I'm trying to see when thinking about what type of tachycardia. Like the QRS complex looks the same to me, so this makes me more thinking about some type of SVT.
Mhm.
And then looking at,
Do you think the mechanism is reentrant or automatic based on this tracing?
I think since we see it rapidly go, or it's like you're not seeing it ramp up, especially since A, we're looking at such a short clip, but B, it goes literally from his sinus rate, which looks to be around 100 before, to this. I think that it's a reentrant. And so then what I'm looking for next is trying to see if I can get any further clues about the RP interval, which it looks like nicely, I think we do. It looks like
Are you looking at the top or the bottom channel or both?
I think you can see them on both, but I think the top shows it nicer actually.
Okay.
Yeah, that little
Talking about
yeah.
this little blip
Yeah.
here.
Mm-hmm.
Yeah. I mean, one could argue that maybe it's here too, but I think even down here, right? It
Mm-hmm.
looks pretty consistent and
Mm-hmm.
a fair bit different than
Yeah.
seeing here. I don't, like maybe this little thing here is something, either this or this is a retrograde P wave, I think, of some sort.
Mm-hmm.
Okay, so do you have any theories on diagnosis then? Obviously, you can't know for sure without catheters in the heart.
Yeah, so I'm looking, so looks like I'm trying to count how far it is. To me, it's looking like that would fill, like being able to see. I was trying to count how far it is from the onset of the
I think it's at least
QRS.
two little
But
boxes.
yeah, that's what
Right?
I'm right. That's what I'm trying to see. It looks like it's a little above 2 boxes. So to me, that's a little bit on the long, like when I'm thinking about AVNRT versus AVRT, it's a little bit longer. So I would think this is AVRT would be my suspicion based on it being a little bit longer than that.
I agree with you fully, Dr. Marshall, even though you're going into that crazy field of heart failure and transplant. So can you verbalize the rule that you use to make that determination between AVNRT and AVRT, or otherwise called orthodromic reentrant tachycardia?
Yeah, so if you're able, I mean, if you're able to see the RP, I think a lot of times it can tip you off that it may be AVRT because the interval, if it's longer than like 70 or if you think 80 milliseconds, because that's like two of the small boxes, that could be more suggestive of AVRT. Whereas if you can't see it, or it's, or if you're looking at it on like a intracardiac EP study and it's less than that, then it'd be more suggestive of AVNRT.
That's exactly right. That's exactly right. So generally speaking, the rule of thumb is that if you can see the retrograde P wave, or if you feel you can see it, probably the R to P interval is greater than 70 milliseconds, and probably it's ORT. Is there another reentrant form of SVT, common SVT, that could also be associated with an RP that is greater than 70 milliseconds?
EAT is a longer RP interval.
Right. You could have EAT, although usually, not always, but usually it doesn't start this suddenly, but it could.
Right there, yeah. But
It
the just
could, but
RP wise, yeah.
right. You could have almost any RP, but this would certainly not be inconsistent. Any other? What about AVNRT? Can AVNRT sometimes have a long R to P interval?
If it's atypical, it can.
Yes, in atypical AVNRT, we go down the fast and up the slow.
Mhm.
And in that case, you can have a long RP interval. Although, again, it is, for lack of a better term, atypical to have atypical AVNRT.
Mhm.
More common to have ORT in young people. So this would be, if we were going to guess, going into the EP study, we would guess this patient has orthodromic reentrant tachycardia. We don't really know, but that would be the best guess. So, let's say, so you're seeing this patient in consultation. So what are the options for treatment?
So wait, can I ask one other question really quick before
Of course, we
for
like.
the just while we're bringing up long RP, for it being atypical AVNRT, there'd be no other way to really know aside from an EP study if it's atypical AVNRT, or is there something else that any other clues that you would?
I mean, the only other clue sometimes you see, and it's kind of not on this tracing, but occasionally people who have AVNRT will have variability in their PR interval, suggesting conduction through slow and fast pathways. So
Oh, okay.
every once in a while, you'll see like periods. Not, when you're asleep, it's not uncommon for people to have a little bit of first degree heart block or to have a lengthening in their PR interval. But sometimes it's interesting. You really do see a fair amount of variability in the PR interval throughout the day, and I've often wondered if that's a sign of, sort of flipping between the two, the slow and the fast pathway in the AV node. But no, I don't think that there would be an obvious, easy way to tell it. There are some algorithms in the adult world where they look at V1 and they make different conclusions based on the morphology of the QRS, but from a tracing like this, it's very hard to tell.
Okay.
And I would not, again, we always say when if we were going to do an ablation in this patient, I would basically go into the procedure thinking to myself, keep an open mind. So I agree with you 100% that this probably is a RP interval that exceeds 70 milliseconds, but I've been wrong many times, unfortunately. So I just never really know for sure.
Okay. So then moving on to
I would say again that we're not pre-excited. So just wow.
So then moving on to
treatment,
kind of what to do about it. Yeah. So you can have the discussion with them that a little bit of kind of shared decision making of depending on how much this happens, but if it's something that they would like to medically manage, you could do atenolol. But this is something that, like, as we've been talking about, could be amenable to ablation in the EP lab. So could talk with them about that. Right. I don't know how much it's, I think sometimes what guides parents' decisions on that is how much it's happening. And how, how much it affects their day-to-day life.
I think that's right. And a lot of parents, in my experience, parents usually fall into one of two camps. The first camp is, I want to see how bad a problem this is. So they want to see if it happens a lot. And some really want to see their child fail a medication before they go to the step of doing an invasive procedure. And then there's another group of parents, in my experience, who really just can't stand the fact that their child has a tachycardia, that they might get a phone call from a coach or teacher that the child is in school and is not feeling well, and they want an ablation almost no matter what. And everybody is different in this regard. And the other thing is, just as you said, Molly, some patients have very rare tachycardia and therefore, are fine with it and can break out of it or have very brief episodes. I have a very good friend who's a pediatric cardiologist who has SVT. And when we were fellows together one day, he went into SVT and we hooked him up to the EKG and he showed us that he could vagal himself out of it right in front of us. I used to have that tracing for many years, then it faded. This was sort of in the pre-digital photo era. That's how long ago it was. But interestingly, now that he's approaching 60, he explained to me the other day that he's having episodes that are prolonged and that he sometimes cannot break them. And he actually had to go to the emergency room once. And so now he's thinking about ablation because he was only having one episode every 18 months or so. But, usually at 12 years of age, we normally do exactly what you said, a so-called shared decision-making plan. And based on that, we decide what to do. I would say in 2024, the majority of patients want to have an ablation. And another thing that I often will mention to families, which is not really pertinent to a 12-year-old, but it is an important consideration, is particularly in girls, eventually women who have tachycardia will have at least be at a higher risk for tachycardia during pregnancy. And our options for medical management are limited because some of our typical medications are theoretically teratogenic or at least dangerous to fetus. And in similar vein, we would almost never do an ablation in somebody who's pregnant because of the multitude of risks that could be posed to a fetus. And so I often will say to families of 12-year-olds who are girls that that is not a rationale to do an ablation at 12, but that, if this becomes a persistent issue, it might be something to add into the decision making for future. But it is an important consideration because I don't have to share. I'm sure you're all very aware that pregnancy is a very significant cardiovascular strain, and in someone who has SVT, will higher risk. So, any questions on this one? Okay, let's do one more. So this is a 15-year-old who has a pacemaker, and we're there for an office chat. And this is the screen, and basically you see that we determined that the pacing threshold in the ventricle was 1 volt at 0.4 milliseconds. And it says here that the doctor, that doctor being me, has it programmed at 2.5 volts in 0.4 milliseconds. So do you think that, first of all, is this threshold a acceptable, decent threshold? And second, what do you think about my decision to program at 2.5 volts with a threshold of 1 volt? I'm going to ask Dr. Capon for her thoughts on this.
Hi, good morning.
Good morning.
So I think in terms of the threshold of 1, I think that's reasonable in someone who that we are interrogating their leads. And
Yeah.
then in terms of your decision to place the output, I believe at 2.5, I think usually on the first initial visit or when you're first initially setting up a pacemaker, you want it a little bit higher, I believe usually closer to 5, but in order to preserve battery life after 1 or 2 visits thereafter, we often bring the threshold out lower. So I wonder if this is a second or third follow-up visit and the leads have thus far been working well.
Okay, so thank you for that. So yes, you're absolutely right, Ivana. A threshold of 1 volt is a good threshold, particularly for a chronic pacemaker lead. We're not talking about temporary leads here. 1 volt or lower would be considered an excellent pacing threshold. For example, if we were placing a transvenous pacemaker, we would be pleased with a threshold of 1. We obviously would even like it lower, but 1 would be a very acceptable threshold. And sometimes when our surgical colleagues are putting in epicardial pacemakers, particularly in someone who's had a lot of heart surgery, it can be very challenging to find an area of the heart that will allow them a better threshold. And Raghav, who often gets saddled with these difficult cases, is really good about moving the lead around if we don't like the threshold, but it is not uncommon that we leave the OR with a threshold of 2 because he just couldn't find any other space. Thankfully, with present lead technology, with steroid elution on the end, it's not uncommon that the threshold will improve with time, but we would generally want a threshold of 1 or less. So a 1 volt threshold in a chronic lead would be considered a very good threshold. So you were mentioning, Ivana, that when we first put in a pacemaker lead, we usually leave the output high. That's absolutely true. So when a lead goes in, again, we would not generally put it in unless we had a good threshold. But let's assume we put it in, we have a nice threshold. The threshold is 1 volt. When it's brand new, we would typically leave it at a very high output, typically something like 5 volts. And the reason for that is because in the first 3 months after implantation, evidence has suggested that lead thresholds can vary. Oftentimes there's scarring that occurs at the tip of the lead, and so the threshold can vary quite substantially. So even though the threshold might be 1 at implant, or even the day after implant, it's sometimes you would bring a patient back to the office like a month later, and the threshold might be 3. Now, I'll be honest in saying, I have not really seen that to any significant degree since the universal acceptance of steroid-eluting leads. And I actually think I've often thought about doing this project. It might be an interesting one, perhaps with an interested fellow, to look at what happens to thresholds in our patients, because I think we're a little overly conservative in 2024. In other words, it's very uncommon in my experience that we see a threshold change that substantially. So yeah, we would normally program it at something like 5 and 0.5, sometimes a little lower. And then typically the general rule of thumb is at 3 months, leads become quote unquote chronic. And at that point, one can lower the output. And as you correctly stated, doing that will very profoundly impact battery longevity. And unfortunately, every once in a rare while, somebody gets a pacemaker, does not come back for follow-up, is left at 5 volts, and at 2 years out is at the elective replacement interval because they never had that follow-up. So I'm always very aggressive in telling families that they must, if they're going to miss any appointment, they cannot miss the 3-month visit, because that's a very important point at which we make important changes to the output. So the general rule of thumb is in a chronic lead, the permanent output should be at double the threshold. So one could argue that I have programmed this somewhat conservatively at 2.5. Sometimes what I will do, though, is if I know that the threshold at another visit was higher, I will leave it at that. Because of the theory that thresholds can change at different times of the day or in different positions. And so in this circumstance, I think my decision was to leave it at that, because I think I had looked back and saw that at the prior visit, the threshold was 1.25. And so I felt like my spot check may not have been, although it was accurate, it may not reflect the threshold at all times. So I decided to leave it at 2.5, which really probably the difference between 2 and 2.5 may only be 3 to 5 months of longevity to the device. So not a very substantial difference, but not nothing either. So yeah, so it is a little bit higher than usual, but knowing the patient in general, I think it was the appropriate choice. Any questions on that?
Thank you.
All right, so I think we'll stop with that. Thanks, everybody. I hope everyone has a wonderful day, and I will see Katoki in the cath lab in a little while. Thanks, guys.
Bye.
Bye.